warm welcome about MBBS Kannur. Today's speaker is Dr. Vijay Ganesh, Senior Consultant Pediatric Surgeon, Sreechand Hospital, and he is speaking on current concepts in pediatric surgery. I invite Dr. Vijay to come to us. The association and the secretary.
Respected President, senior members of the Royal and my friends. President's Secretary, Local Branch, President Secretary meeting diary, Provanda Maya Village, President Sreechand, Kannur representative Pangatil diary. Adele Pradhanamayitum diary Church, hospital violence. Adamai Mother Gary. President of Kamayitum Avashapatan, or local branch. It's a Vishal Karamat preparations in Akamana. Munkarana after the Korea, number of badges, the protection of the Karamat. A penny or a branch of the year and issues very honorable. Or immediate or lightning strike leg and hold the other branch. Tayara other preparations for a branch, Nartham and IMA state branch architect. The branch reaction committee in Dhaka. Other or a hospital senior representatives or a hospital's more four group of Indaka. For a branch level and a currently church out of Kutimaya, the yard hospital violence in the Virana, Nerada Montator, the yard of Provana, Avashapata. Namukanda church action committee and the executive committee and the church. What are the panel discussion and the Arthan with the Magazine Pulpiticonda. On the January master panel discussion would be Artha. Hospital violence or a member mark or a branch in our member mark, our Protecamite IMA Arika and although Arika, Natasha Arika on the project. Otherwise, the particular parameter. New Year program January, the Shania chair is partner. For the Korean member market request and the Shania chair, Vara Chatan, not the Korean prime. Somebody can have a regular meeting, Yara Chatan, a mechanical program.
We are continuing from hospital management.
Sorry, not hospital management meeting. അപ്പൊ ഒരു Thursday മീറ്റിംഗ് നമുക്ക് എന്തായാലും പ്ലാൻ ചെയ്യാം. അടുത്ത ആഴ്ചയെ പറ്റും നോക്കാം. അങ്ങനെയാണെങ്കിൽ ഹോസ്പിറ്റൽ മാനേജ്മെന്റ് പിന്നെ നമുക്ക് പബ്ലിക് ആയിട്ടുള്ള ആരെങ്കിലും വിളിച്ചിട്ട് അത് നമുക്കൊന്ന് പ്ലാൻ ചെയ്യാം. ശരി, താങ്ക് യു.
Next is introduction of the speaker. I welcome him.
Good evening all. Pediatric surgery, like in other branches of medicine, has undergone rapid advancement, and we have got a pediatric surgeon to enlighten us regarding the current trends of in pediatric surgery. It's my pleasure to introduce Dr. Vijay Ganesh. He's a consultant pediatric surgeon from Sreechand Hospital, Kannur. He completed MBBS from Government Stanley Medical College in 2003. MS from Government Tanjavur Medical College in 2008. Completed MCH from Madras Medical College. He has worked in Global Hospitals Chennai, Valluvanad Hospitals Ottapalam. He worked there in Ottapalam for 6 years and is well versed in Malayalam also. He also worked in Medicover Women and Child Hospitals. His core interest is in pediatric urology and laparoscopy. He is a fellow of European Board of Pediatric Surgery, fellow in Minimal Access Surgery, and fellow of Indian Association of Gastrointestinal and Endoscopic Surgeons. He is a member of Royal College of Surgeons of Edinburgh, and he has presented various papers in national and international conferences. I welcome Dr. Vijay Ganesh for the speech.
Good evening to all. I'll just introduce the team that is there working with us in Sreechand Hospital. This is a department of gynecology, obstetrics and gynecology. We have 2 gynecologists, and we have 3 pediatricians, and one of them is an intensivist. So we have a well-equipped PICU managed by Dr. Sarat. And I am a pediatric surgeon there, joined 3 months back. I thought I'll just give a brief introduction to pediatric surgery rather than going into details and advanced things. So the basic cases that come. So broadly, I would classify the cases into elective and emergency, either during newborn period or pediatric period. So newborn emergencies, for example, the first X-ray shows pneumoperitoneum, free air inside the peritoneum in a newborn. That usually occurs post-necrotizing enterocolitis. It's a complication of NEC, necrotizing enterocolitis. We call it as football sign. We usually manage with a flank drain initially, stabilize the baby, and then take up for laparotomy. It might lead on to either a resection anastomosis or a ileostomy, depending on the condition. The second X-ray, male baby, either in the newborn period or in the pediatric age group, coming with poor stream of urine or dribbling of urine. On examination, the per abdomen, there will be a palpable bladder, something like a tennis ball, it will be felt. We do that X-ray is called a micturating cystourethrogram. We insert contrast through the urethra with a feeding tube, and then we take the X-ray. What we could see is that this is the posterior urethra, this is the bladder, this is the posterior urethra, this is the urethra. So we can see the dilated posterior urethra in this MCU, which indicates that there is a valve here, this part. So that there is block here and the posterior urethra is dilated. What we do, previously they were doing vesicostomy followed by cystoscopy in the pediatric age group and fulgurate the valves. Now single stage cystoscopy fulguration, we have newborn cystoscopes, or even pediatric cystoscope can be used in newborn after dilating the urethra. We use electrode, either a Bugbee electrode or a resectoscope assembly to cut the valves. The prognosis of PUV usually it depends on the extent of kidney function. Rather than fulgurating valves is a surgery, but long-term survival of the posterior urethral valve babies depends on the development dysplastic changes in the kidney and how the kidneys behave in the long run. The third picture is in a newborn with absent anus. We can see there is no anal orifice there. The anus will be absent in these babies. Immediately they will present on first day or second day of life with progressing abdomen distension. This is a male baby. We do X-ray prone translateral view. Previously it is called invertogram. Now it is called prone translateral view. Immediately after that X-ray, we plan a staged procedure. During newborn period, we just divert the meconium by doing a colostomy on the left side of the abdomen. We do a sigmoid colostomy. Then second stage, we do a anorectoplastic, either a pull through or a posterior sagittal approach. Between the buttocks, we make some incision and bring the rectum down and make a rectoplasty, create the hole here. The third stage will be closure of that colostomy, which we first operated in the newborn period. All will be varying within 1 year period. All the 3 operations will get completed. In female, it is almost the same. There will be meconium coming through the vulval orifice. There will not be any anus, but the meconium will be coming through the vagina. Those babies also either a single stage approach or 3-stage approach, depending on the anomaly. So there are 3 types of anomaly: high, intermediate, and low. We classify and then operate. This X-ray, these 3 X-rays correspond to ileal atresia, ileal or vaginal atresia. This is the X-ray showing multiple small bowels. Usually the baby will present during 3rd or 4th day of life in the newborn period with profuse bilious vomiting, green color vomiting. Any green color vomiting in the newborn is always surgical. So profuse bilious aspiratory, insert NG tube over 24 hours, we get 50 ml, 100 ml. So that means the bile which is secreted into the small bowel is not going distally. So the entire colon will be unused in those babies because it is a block in the small bowel level. There is an atresia, the bowel is not formed. So we do a contrast enema, we can see that collapsed colon, small colon, because there is no bile to distend the colon. That is called microcolon. And so this is the operative picture. We could see the atretic bowel. This is the dilated end. The proximal bowel at the site of atresia becomes dilated because of collection of meconium there. And the distal segment will be collapsed and atretic as shown in this picture. So these 3 X-rays. The next one, the same bilious vomiting in the newborn period, profuse bilious vomiting. We do an ultrasound that shows malrotation. The SMA, SMV axis will be altered. This is what a malrotation will be. That is because of freely hanging small bowel, it twists on its own axis. So it becomes a volvulus. That is the related surgical emergency. We immediately do a laparotomy and operate. Then the next, these 2 X-rays. This is the X-ray of a newborn showing a double bubble appearance. Double bubble is gastric bubble and duodenal bubble. The next is the operative picture. We see the duodenum blindly ending here. So the duodenum, this is duodenal atresia, double bubble sign. The previously this was ileal atresia. This is duodenal atresia. So we do a duodenal anastomosis. These are all newborn emergencies which I will comment. So bilious vomiting in a newborn, suspect surgical condition. Dribbling of urine, difficulty in passing urine, suspect surgical problem. Bilious emesis, the surgical causes of bilious emesis, these are the So further going on to newborn emergencies, this is one picture showing an obstructed hernia or incarcerated hernia. Newborn period, preterm or term baby, irrespective of the gestational age, the term maturity of the maturity, we operate. So hernia is a relative emergency. We have to operate as early as possible because the chances of obstruction and incarceration is very high in pediatric age group. So there is no point in waiting once a hernia is diagnosed. Parents have to be told that immediately, as early as possible, the baby has to get operated. These two are the pictures of Hirschsprung disease. Hirschsprung disease is one disease where the large bowel, the neuronal migration into the large bowel has not occurred properly. Normally we need nerves supply for the entire intestine for appropriate motility. In Hirschsprung disease, what happens at some point, the neuronal migration abruptly stops. So beyond that point, the colon will become smaller in size, unused colon, aganglionic bowel. And proximal to that, where the neurons are normal, it will be dilated. So this is the operative picture. This is the contrast cinema. Usually the baby comes around, it may come in the newborn period or in the pediatric age group, or even at 10 years, 12 years, delayed presentation also can occur. Patient will have recurrent constipation, abdomen distension, anemia, failure to thrive, lack of appetite and failure to gain weight. Those cases, we do a contrast cinema, we see this unused colon here. This is the proximal dilated. If we see horizontally, it is something like a swan neck deformity, they call it. So this will be the unused colon. This is the proximal dilated. What we do colostomy in the dilated bowel path, and then later on, after 3 months or 6 months, we do a pull through. Pull through is the pulling of the long normal bowel into the rectum. The aganglionic bowel, either we discard it or use it as a cuff. It depends on the type of surgery. And these are all newborn emergencies. This is gastroschisis, where there is the entire intestines are exposed outside. Morbidity and mortality is high for these babies. As early as possible, we have to push in those bowel inside and close the abdomen. So gastroschisis is one abdomen wall defect in newborn. This is omphaloceal. There will be a sac covering the prolapsed intestine. The umbilical ring will be defectively closed in these babies. So the intestines come out and they are covered by a sac. Depending on the defect, we either just cover it with mercurochrome so that the sac becomes thickened and forms a skin layer. Later on, we close it as a hernia, ventral hernia. Or otherwise, if the defect is small and the baby doesn't have any comorbidities, we immediately operate. We push all the contents inside and close the umbilical ring. And these two pictures, we can say a newborn antenatally diagnosed congenital diaphragmatic hernia, baby is having oligohydramnios. Postnatally, baby will be delivered in a tertiary care hospital. There will be respiratory distress at birth, and the X-ray will show presence of small bowel or bowel gases inside the chest, left hemithorax. This is the picture. We see a defect in the diaphragm, congenital diaphragmatic hernia. There is a defect in the diaphragm through which all the intestines will go into the thorax. So what we do, the main problem in these babies will be pulmonary hypertension because of the poor lung development. We stabilize the baby, control the pulmonary hypertension, the ventilatory support, surfactant therapy, all this, and then we take up for surgery after stabilization. It will be either a thoracoscopy or a laparoscopy or laparotomy, either thoracic or abdomen approach. We reduce the intestines, we close the diaphragmatic defect. 60 to 80% of these babies survive. Now the survival rate has approached almost 100%. If there are no comorbidities, no major cardiac anomaly, and echo is normal, and baby weight is more than 2.5 kg, the survival rate is almost 80 to 100%. These two are tracheoesophageal fistula in a newborn. This is the azygos vein. This is the lower pouch of the esophagus. This is the upper pouch. There will be a defect here. This is the commonest anomaly in esophageal atresia with the tracheoesophagus. We call it as OA with the TEF. Proximal pouch will be atresia, the blind ending upper pouch of the esophagus. Lower pouch of the esophagus will be communicating in the airway. That is called tracheoesophageal fistula. So what we see, the newborn period, there will be distress, respiratory distress at birth. Then there will be frothing of saliva from the mouth because the saliva cannot go inside the esophagus. The baby will have continuous frothing. We insert NG tube and take an X-ray, there will be coiling of the NG tube. So we do it either thoracoscopic repair or thoracotomy repair after sterilization of the baby. Another newborn emergency, this is congenital lobar emphysema. This is congenital cystic adenomatoid malformation. These two are emergencies. We can see the mediastinal shift here, the huge emphysema because of a large congenital vulvae there. This is the lobar emphysema. We do a lobectomy. Newborn electives, umbilical hernia. There will be between newborn electives and pediatric electives, there will be overlap of cases because many of the cases in the newborn, we don't operate immediately. Umbilical hernia, we don't operate until 2 years of age. The defect of 1.5 centimeter or more in children over age of 2 years, we operate. Hydrocele in newborn period, if you diagnose, we don't operate until first birthday. After first birthday, if still the hydrocele is persistent, huge, then we operate. Minimal hydrocele ultrasound they give, we don't intervene, we just wait. And physiological phimosis, during the newborn period, we see phimosis there. We don't operate immediately. Usually by 1 year of age, all the additions in the subprepucial region will get released and the skin will get retracted. So any symptomatic like ballooning of prepuce during urination, constant handling of genitalia, frequent itching under the penis, those things we operate beyond 1 year of age. Otherwise, only religious indications we do circumcision in the newborn period or infancy. Tongue tie after usually before 1 year of age. From 6 months to 1 year, we operate because once tongue tie is diagnosed, the child cannot say certain words. So those words get registered in the brain. And future, maybe I've seen cases coming at 5 years, 10 years, tongue tie release. But after that, they have to go for speech therapy to get the things corrected. Otherwise, these words will get registered in the brain, which needs time for correction. So ideally, around 6 months to 1 year, we operate a tongue tie. Hydronephrosis is a big topic. It is swelling of the kidneys. We depending on the condition, we operate. If it is associated with the PUJ obstruction, periureteric junction obstruction, which is commonest cause of hydronephrosis, we do an ultrasound and then followed by a nuclear scan, DTPS scan or EC scan. And then depending on the level of obstruction, we operate. So hydronephrosis, hypospadias. Hypospadias is where the hole in the ventral surface of penis. Congenital abnormality where the child will pass urine from the ventral surface rather than tip of penis. There are varying grades of hypospadias. We have to operate. It may be a single stage operation or a 2 to 3 stage operation. And undecided testis, beyond 6 months of age, the testis doesn't descend into the scrotum. If it is higher, either inside the abdomen or in the inguinal region, we have to operate either open or laparoscopy. By completion of 6 months, the testis doesn't come. This is newborn electives. This is just the picture. Whatever I have said. This is umbilical hernia. This is hydrocele. This is low flow venous malformation or hemangioma, which we call as hemangioma. Newborn period, we often manage these kids with only tablet propranolol. 2 milligram per kg in 2 divided doses we give. Usually they respond very well to propranolol. So surgery is rarely we do in hemangioma cases. This is pyloric stenosis. We will see in future slides. We have done a Ramstead pyloromyotomy. We just break open the muscle. This is hypospadias, what I have told. These are varying grades of hypospadias. You can see hole in the ventral surface of penis. We have to correct it in stages. Then cystic hygroma. This is baby is having cystic hygroma or limb cyst, common in the newborn period, swelling, huge swelling in the neck. We give bleomycin 0.5 milligram per kg body weight. Bleomycin is for cancer chemotherapy they use. It's a sclerosant. We give it intralesionally into the cyst. We give either under ultrasound guidance under sedation in OT we give it. Roughly 4 to 6 sittings we give every 3 weeks apart, and they respond usually well to bleomycin. Low flow venous malformation we have seen, choledochal cyst, biliary atresia. These are all newborn elective cases which can come incidentally diagnosed by ultrasound or by an MRCP. And pyloric stenosis, any for beyond 4 weeks, any baby with projectile vomiting, curdy vomitus, like a curd, the vomitus will be like a curd. Ultrasound we do, they give IHPS or pyloric stenosis. More than 6 millimeter in thickness, then we have to operate. What we do is pyloromyotomy. It's either open or laparoscopy, go by a small incision, and we just break open like a coconut, we just break it open. The mucosa will be intact. We don't suture the muscle, we just open the muscle, leave it open. Mucosa will be just bulging through that thing. We should not injure the mucosa. That's a procedure we do, so that immediately after 24 hours, we start feeding, maybe another 2-3 days, we discharge the baby. That is one common surgical in the newborn period. In polydactyl extra fingers, we remove it under local. And cleft lip around 3 months, cleft palate around 8 to 9 months of age, we operate. And inguinal hernia, discussed previously, extrophy bladder, we'll see in the future pictures. And ovarian cysts, neural tube defects, choanal atresia, duplication cysts, these are all common things. And this picture is the MRCP picture of a choledochal cyst, cystic variety. Huge cyst-like thing in the entire extrahepatic biliary tree will be converted into a huge cyst. These children will present usually with recurrent ascending cholangitis, fever, jaundice, failure to gain weight. We do an ultrasound, they say choledochal cyst, MRCP shows this picture. What we do is we open the abdomen, we cut the cyst, remove the cyst, and then bring small intestine directly suture to the hepatic ducts, common hepatic duct or individual hepatic ducts. We do a Roux-en-Y jejunostomy. And this is the intraoperative picture of biliary atresia. Biliary atresia is one condition in newborn period where baby will have prolonged persistent jaundice. They will have high conjugated bilirubinemia. They will have clay colored or white stools. They will not pass greenish stools. Baby will have firm liver. So these babies we have to operate. Unless we intervene within diagnosis should be early, and our intervention should be done at least before 2 months of age. Because beyond 2 months, the liver will go for irreversible cirrhosis. Then liver transplant is the only option we have for those babies. And spina bifida, either it's a covered or incomplete, covered meningocele or open neural tube defect. Those things we operate. This is extrophy bladder. Previously shown it, and this is the picture. The bladder will be open, urine will be coming out from the lower surface of the abdomen. There will be urine smell, constant wetting of diapers. We operate either in the newborn period or after 4 or 5 days after stabilization. These also stage procedure. It's a complicated procedure. It's not so easy as appears. We have to close the bladder capacity has to improve. So it's multiple stage procedures are required for this. Polydactyly, tongue tie, I have told previously. And constant umbilical discharge. Newborn period, babies beyond 2 weeks, there will be constant umbilical discharge coming out. Sometimes urine will come out, sometimes intestinal contents will come out. It may be either a patent urachus or patent vitalo-intestinal duct, depending on the discharge that is coming. We have to do further investigations and operate. Umbilical granuloma, the differentiation, umbilical granuloma, usually they resolve. By 2 weeks of age, they resolve. There will be no further discharge. Sometimes small tissue-like thing present in the umbilicus without any discharge, it will be dry for most of the time. Those things we will just cauterize it or apply copper sulfate, it will settle down. And cleft lip, cleft palate. Coming to pediatric emergencies, the commonest one we have is interception. Majority of the cases, 6 months to 2 years or up to 5 years of age group, baby will have persistent sudden onset of bleeding PR, abdomen pain, incessant cry, vomiting. We do an ultrasound that will show a target sign like this target sign. The small bowel goes into the large bowel, ileocolic intersection. The one bowel will invaginate into another bowel. The treatment of choice now of late, we do only pneumatic reduction or hydrostatic reduction in majority of the cases. Pneumatic reduction is just we pushing air from the rectum, we shift the baby to OT, give some sedation. From below, we pushing air. Usually that air pushes the small bowel outside from the colon. Invariably, it will be successful. If we push water, that is hydrostatic reduction. Ultrasound guidance, we do it. If both these are not successful, then we go for laparoscopy or laparotomy reduction. We either laparoscopy or we open the abdomen. Invariably, the baby is not responding to pneumatic reduction, those bowel would have gone in for gangrene. So laparotomy, we do a resection and anastomosis. So foreign body injection, coins and other sharp foreign bodies, anything can come. If it is in stomach, any foreign body, if it is in stomach, better to do an endoscopy at that time and retrieve the foreign body. If it goes beyond the stomach into the small bowel, then we wait for majority of foreign bodies to automatically come out. We don't give any medicine, just wait and watch. By 5th day or 6th day, invariably the foreign bodies come out. Only those foreign bodies which are we have to be cautious are the button batteries and magnets, which are found in some of the toys. Button batteries are chargeable foreign bodies, so they are notorious for perforation. So we have to keep a close follow-up of those foreign bodies, button batteries and magnets. And this is one ultrasound picture of an appendix, pediatric emergency. The ultrasound shows more than 5 mm thickness of appendix. We operate. The correct deadline is 5 mm. Beyond 5 mm, and the mesenteric inflammation, periappendiceal inflammation, mesenteric thickening, all those things, cemental inflammation indicates that it's inflamed. We have to operate. We do it laparoscopically in majority and laparotomy rarely. Blunt injury abdomen can come, pediatric emergencies, any hollow stress injury or a splenic injury, liver injury. Depending on the type of injury, we manage appropriately. And Meckel's diverticulum, this is common in pediatric age group. Usually they will have bleeding PR around 3 years, 4 years, beyond 3 years, 4 years child with recurrent abdominal pain and bleeding PR. Ultrasound bleeding Meckel shows Meckel's diverticulum, we operate. We do a resection anastomosis. And this is obstructed hernia. We have already discussed pediatric emergency, any pediatric group. Obstruction is common. Hernia, suddenly the parents will say this swelling was present for 1 month. Suddenly yesterday onwards, it doesn't go inside. Child is having severe pain and vomiting. And when we operate, usually it will be a gangrenous bowel or incarcerated bowel. So hernia has to be operated. So pediatric electives, we have previously discussed undescended testis, inguinal hernia, worm colic and habit constipation is the commonest OP emergency, OP patient we see here in practice. Patient with recurrent abdominal pain, lot of junk foods, and they pass motion once in 3 days, once in 5 days, once a week also. These children we have to appropriately manage with the dietary modification. We have to advise them adequate fluids, avoid junk foods, adequate vegetable fiber, all vegetables, adequate fluid intake, and we have to 3 weeks give toilet training with suppositories and laxatives. Hypospadias, corticosteroids, empyema is one case we get from physicians. We do a thoracoscopy decortication. Right now we are more into VATS procedure for empyema. We drain the pus and insert ICD. Thoracoscopically we do it. Small bowel obstruction may be due to Meckel's or congenital bands. These can come. Any pediatric age group child with X-ray showing large small bowel dilated small bowel dilatation. Those cases we have to operate. First round disease we have discussed previously. This is one thoracoscopic picture of TEF repair. These are all the videos. Okay. Just this is a tracheal fistula thoracoscopy video. We do it thoracoscopy, we ligate the fistula, which I have told we ligate the tracheal fistula and do a end-to-end esophageal anastomosis. This is a pyloromyotomy video, pyloric stenosis, and this is a laparoscopic hernia repair in a pediatric. And this is a ovarian cyst in a newborn baby. We laparoscopically remove the ovarian cyst. Ovarian cyst in newborn more than 5 centimeters, we have to operate for fear of torsion and hemorrhage. Almost all of these we have discussed. And this is one ileal atresia picture in a newborn. This is the unused microcolon which I have said previously. The contrast schema will show this microcolon. The entire colon will be very small. The bowel, the proximal bowel will be dilated and the distal bowel, the atretic bowel will be collapsed. This is a classical visible gastric peristalsis in a pyloric stenosis, gastric outlet obstruction or pyloric stenosis. We'll see this distended stomach with VGP. This is a NEC baby, we do ostomy, perforation, peritonitis. And another thing, eventration of diaphragm. Eventration is the weakness of diaphragm. Usually comes in the pediatric, presence in the newborn or pediatric age group with a recurrent respiratory tract infection, failure to gain weight. These also we operate either thoracoscopic or thoracotomy. We plicate the diaphragm. We just plicate it and make it dark. Sacroesophageal teratoma in newborn period. Torsion testis. Initial child, pediatric or newborn baby with sudden onset of swelling, scrotum, pain, scrotum. Ultrasound shows torsion testis. We have to operate immediately. The window period is usually 6 hours. Beyond 6 hours, the testis will go for Gannet. Invariably, torsion testis, majority of the testis they go for architectomy because the survival window period of the testis is very less. If testis is viable, we derotate it and fix the orchidopexy. We fix the testis. This is malrotation. This is the entire small bowel. And just few cases, 6-month-old infant with vomiting, poor intake and abdomen distension, non-bilious emesis, looks ill, some respiratory problems as neonate. So the main symptom is vomiting, poor intake and abdomen distension. X-ray shows small bowel dilated loops. And we examine the hernial orifices, shows either female, it's an incarcerated ovary or a small bowel, and the male, it will be the incarcerated hernia. So this hernia in a newborn in a pediatric age group is due to patent processes vaginalis. Because of the patency of this opening, usually the opening on both inguinal orifice should close after birth. In hernia babies, this hole will not close. So through that either ovary or small bowel, anything will come out. That is the pathophysiology of the hernia. So we do a herniotomy. We reduce the contents, we close the hole. That's it. We don't do a mesh repair like in adults. Only herniotomy. It's not hernioplasty. And this is a 6-month-old infant with vomiting, poor intake, and abdomen distension. Looks well. Mom says intermittent fussiness, and the main thing is reddish thick mucus stool. Baby is otherwise normal. We call it as recurrent jelly stool, and that is intussusception. So plain X-ray and abdomen, small bowel dilatation will be there. This is a picture, intraoperative picture of incomplete air reduction. Then a 6-month-old infant with vomiting, poor intake, same abdomen distension, green emesis. Any bilious vomiting in a pediatric age group, we have to suspect malnutrition. Malnutrition we have seen previously. This is the basic pathophysiology. It rotates on its own axis. This is malrotation with volvulus. Case 4, 5-week-old infant. This we have discussed, projectile vomiting, curd-like vomitus. So 5-week-old, pyloric stenosis by ultrasound, hypokalemia, hypochloremic alkalosis will be there in these babies. And this is how the pathophysiology. This is the thickened pylorus. It is very narrow, so the contents of the stomach will stay there for a long time, and the baby will have recurrent vomiting. This is the thickened pylorus. You open it and leave the mucosa intact. The muscle is split and the mucosa is left intact. This is one 4-day-old female presents to ED with lethargy, abdomen distension, emesis. Mom says patient is not making as many diapers as his twin sister, not eating as much. Her abdomen distended, rectal examination, the gut of hair will be there. Sick babies, Hirschsprung disease, we have discussed, X-ray abdomen. This is the transition zone. This is the normal ganglionated bowel, and this is aganglionic collapsed bowel. This is the transition zone. This is there where we do a colostomy. We do a colostomy here. We do multiple bowel biopsies. These are all the site of biopsies to confirm where the ganglion cells are there and where it is not. 6-year-old, otherwise healthy, presents to pediatrician, abdomen pain and nausea, sudden onset of abdomen pain, vomiting, occasional constipation, plain X-ray abdomen erect. We see sometimes rarely fecolith. Fecolith can be seen, something like this. And this is the ultrasound showing acute appendicitis. This is the sausage-shaped structure, classical inflamed appendix. If necessary, we do a contrast-CT abdomen. So a sign will the child will walk with an hunchback because of irritation of appendix into the psoas muscle. So child will slightly bend forward. And we do a laparoscopic appendicectomy. These are Meckel's diverticulum, gangrene because of congenital band attached to the Meckel's diverticulum, causing volvulus of the small bowel and gangrene. Resection anastomosis. Jejunal atresia, classically you can see here, this is the dilated bowel. Beyond this, it becomes collapse. This is where the atresia will be. We do a resection anastomosis with these babies. Testicular torsion. Swelling scrotum, ultrasound we do, torsion testis, and we open it, then it will be, the testis will be gangrenous. And foreign body airways can occur, either check valve obstruction. Check valve is one where the air goes in but doesn't come out. So huge emphysema like lung will come. Or stop valve, where the air will not go inside at all. So there will be collapse of the involved node. And foreign bodies we have discussed. Best is to treat it with remove endoscopically if it is in stomach. And some of the common confusions, constipation, when to suspect a Hirschsprung disease. All constipation are not Hirschsprung disease. Majority of them will be habit constipation. They have, Hirschsprung disease when we suspect child is anemic, failure to thrive, gradually progressing distension, not eating well, and we do a contrast enema, then we will see a definitive transition zone in Hirschsprung disease. Otherwise, the habit constipation will have constant soiling of underpants. There will be scissoring while the child will stand and pass motion. Those things will be there, and it will be a recent onset. Habit constipation will be recent onset. First 2 years, 3 years, the child will be normal. Beyond 3 years, only these the constipation symptoms would have started. So habit constipation is more of an acquired variety, whereas Hirschsprung disease will be present since birth. The meconium passage will be prolonged. The child will be very sick. distension of abdomen will be there. So in those cases, we always will go with a contrast enema and if necessary, a rectal biopsy to rule out Hirschsprung disease. Then ilioileal interception. Some scan reports will have ilioileal interception. That is nothing to worry. Usually it will settle down. After a diarrheal episode, it will come. It may automatically settle down. We don't operate in ilioileal interception. Only ileocolic we are worried. Ileocolic or ileocolocolic. Ileoileal in an elderly age, around 7 years, 8 years child with ileoileal interception. Again, you repeat the ultrasound the next day, it is still persistent. In those cases, rarely a lead point in the small bowel, like a Meckel's diverticulum or a lymphoma, can cause a ileoileal interception. In that case, we have to do surgery. In the older age group, not in the pediatric, it is very rare. And some reports show mesenteric adenitis, lymph nodes in the abdomen, that is normal. Those are all insignificant lymph nodes that will settle down with antibiotics. Invariably, all children, when we do ultrasound, mesenteric adenitis will be there. And a dengue and abdomen pain, they will mimic appendicitis, acute abdomen. So always dengue serology and platelet count, we have to tread cautiously in those patients. Unnecessary surgery has to be avoided. And some ultrasound will give pericholecysttic fluid, that is also normal. And gallbladder stones in pediatric age group, invariably we manage it conservatively. We don't go for cholecystectomy in all GB stones in pediatric age group. Just UDCA and supportive therapy, repeat ultrasound after 3 months. They will be usually asymptomatic and we need not operate in all GB stones, except in spherocytosis, hemolytic anemia, hemolytic jaundice, where there will be pigmented stones. Those cases we operate because those are known for complication. In those cases, if necessary, we operate. Empyema, early intervention, we have discussed video assisted thoracoscopic surgery. Earlier the intervention, the better the outcome. Because later on, beyond 3-4 weeks of empyema treatment, the pus will become very thick. It is very difficult to remove by thoracoscopy. You have to go for thoracotomy only. And persistent umbilical discharge. This we have shown in the previous picture. This is patella vitellointestinal duct remnant, urachus or umbilical gland. Urachus is one which communicates to the bladder. So there will be urinary discharge from the umbilicus. PVID is communication to the intestine. There will be bile coming out through bile or fecal material coming out to the umbilicus. Umbilical granuloma is just cauterization, or this is the close DD of all umbilical discharge. These three. So, contrary to popular belief, bowel movements may be present even in obstructed children. So, the only definitive sign is passing flatus. If the child passes flatus, most of the cases the obstruction is not there. So, it's one of the clinical signs to differentiate. So, we are so much interested in flatus. Thank you.
Thank you, Dr. Vijay, for the excellent and good memory of prayer discovery. The topic is open for discussion.
Very to operate.
Thank you. We want to usually the permission pediatric. So once we diagnose, we operate because we have tape as there's no one way. The system for it. Yes, the immune system part of the higher one also. Yes, sir. But there is no special age limit for the any what are the indications? Usually newborn period we do a thoracoscopy in diaphragmatic manner or a laparotomy. The older age group, it can be more of a laparoscopy. Newborn period, the abdomen compartment will be very small. So we cannot do laparoscopy. The laparoscopy, the human is limited. We do either laparoscopic reduction or a laparoscopic reduction. As the child which is pediatric, the abdomen grows more, there will be more space to operate. So laparoscopy is safer compared to laparoscopy as the age.
But laparoscopy is a emergency or surveillance.
Delayed extremity unlike handcuffs. Congenital extremity in a presentation can be early or late. If they not diagnosed initially, 2 years, 3 years later also they have. So those are lesser variants. Where the entire intestine would not have gone. Only a small group of intestine would have gone. So delayed development.
You want laparoscopy. Will you prefer laparoscopy or laparoscopy?
If the comorbidities are not there, if there is no major cardiac kidney is maintaining or group saturation is good, weight more than 2.5 kg, have to a laparoscopy. Suppose in the baby is less than 2.5 kg, not on weight is good, I would prefer a laparoscopy rather than laparoscopy because of unnecessary prolonged duration of surgery and we take the cardiac those things can be avoided. Yes, first degree.
Regarding posterior what is the outcome? What is the outcome of chronic failure?
It all depends on the degree of dysplasia, renal dysplasia. What I say is creatinine at the 7th day of life. Before 5th day, at least 5th day. Before 5th day of life, it is maternal. At day 5 of life, if creatinine is more than 1, then around 60 to 80% will go for renal prioritization around 7 years. This is a rough problem. Creatinine at birth is one important prognostication factor in the more than one on day 5 of life. Immediately after birth.
Regarding like you said, you do pneumatic or microscope under sedation. Then how do you protect the air? How do you protect the airway?
No, sir. Usually by sedation we can do it. It doesn't cause gross discomfort.
You do not
Ultrasonic hydrostatic reduction. I personally advocate pneumatic reduction. I don't do hydrostatic reduction. Procedures that are available are pneumatic or hydrostatic reduction or laparoscopy, the other extreme.
But you might say that because people where most of the patients are incompetent with regular.
Incompetent, they are fat. They are competent.
Also, the patient when I was going on, they were doing without also paid. And most of the time, we are seeing going coming out to the. So, if the airway is not connected, the baby will die.
That's the advantage of pneumatic reduction. Hydrostatic reduction means pneumatic reduction is just pushing there and just beyond there. This is
No, you are looking at the
that will be this beyond the advantage.
regarding the anatomy of mobile canal of a baby and an elder.
The most superficial and deep will be obliquely placed in adults. That will be the newborn or the pediatric both internal and superficial are the same. There is no canal access in pediatric.
No more questions. One of them is the laboratory.
Good evening, everyone. Today, we have Dr. Vijay Ganesh. He talked about the current concepts in pediatric surgery. Our sincere thanks on behalf of EMA Kannur. Thank you, sir, for accepting our invitation. And I extend my sincere thanks to one and all of EMA Kannur for attending this meeting. Thank you.
It is the James Bond.